It's the AEMT lecture series. Welcome back. This will be video number 1 for chapter 17, respiratory emergencies. So welcome. A lot to go over. There is a lot to talk about in this chapter. So let's just get started into the chapter. I think by now that we have an idea that dyspnea is difficulty in breathing. We should know that by now. That's one term we should know. It's a very common complaint. We see this almost every day in a 911 call of some type, and we see how those symptoms they vary. I mean, from one end to the spectrum, very minor difficulty in breathing, to the other end, which could be critical patient who is in respiratory failure. So we have to take the complaint seriously. Of course, we want to keep the patient's medical history in the back of our mind. It helps us to make critical decisions. It helps us to make diagnoses that are correct. Irregardless of whether we can determine what the cause is of the respiratory distress, we know how to treat it. We need to know how to treat it. We need to know how to recognize a patient who is in moderate to severe distress, maybe knocking on respiratory failure's door. All right, reviewing the anatomy. Again, we're getting kind of deep into this. This anatomy hasn't changed since your EMT class that you had. You're moving to AEMT. It's even more important for you to understand a couple of things. One, the anatomy, the function of that anatomical piece that you're looking at, and it's also very important to understand the physiology behind that piece. A review here, we can look at the upper respiratory system versus the lower respiratory system. The function of the upper respiratory system is to, humidify air. It's a filter, making sure that we're not getting, particles that don't belong in the lower airways. It prevents that. Now, if we look at the lower airway, the function of that is simply gas exchange. It's an important function nonetheless. If we look at some of the anatomy, we have the pharynx, and we're familiar with that, the throat, right? And we have a nasal pharynx, we have an oral pharynx. The epiglottis, we know the larynx is the dividing point between the upper and lower airways. We keep moving down to the trachea. That's going to deliver the oxygen from the outside environment down the trachea to the bronchioles. Okay, we know that those bronchioles become smaller into bronchioli, extending down to the alveoli. At the alveoli level, we know that we have the capillaries. Okay, and here we have a picture of that. We know how the capillaries work. The capillary bed's very close to running right on top of that alveoli. That's needed because it needs to be close. Because the further the alveoli move away from the capillary bed, the harder gas exchange becomes. And you see here, you have the blue in this case as the pulmonary artery, the only artery that's going to carry unoxygenated blood, comes in, drops off that dirty CO2, picks up fresh O2, and that's reflected here in your pulmonary vein. That's going to go back into the left atrium. All of that's very, very important. If you're struggling with that, if you don't get it, you have to get it. You need to come see me. Come see me, and let's get that straight, because you'll never be able to critically think in the field unless you get that. And the next slide just kind of breaks down gas exchange, the one on the left. It pretty much shows you, the gas exchange process starts here in the left ventricle. I'm trying to get a pen up here. Hang on one sec. And, well, it doesn't want to cooperate. That's okay. Here in the left ventricle, okay? And then it's going to, excuse me, that's where it starts, but we know that it's going to move up through that pulmonary artery into the alveoli, where it meets up. We saw that picture in the last slide. Meets up with that, makes gas exchange through diffusion, and then travels back to the left atrium right here. And then from there, we know goes through the bicuspid valve into the left ventricle, and from the left ventricle through the aortic valve out the aorta. And we call that systemic circulation. Once it leaves the aorta and once it gets in the aorta and goes out to the body, that's systemic. But all of this over here is pulmonary circulation. The slide on the right basically showing you some of the differences here. We can tell that the nasal cavity area of a child is more narrow, but we also have a proportionally larger tongue because the area is smaller, making an airway more difficult, and also causing that tongue to be very suspicious for airway embarrassment. It could block that airway very easily. All right, so there's two processes that we're going to talk about today. One is inspiration, one is expiration. I want to cover something though, so that make sure everybody understands when we talk about definitions. One is for ventilation. Ventilation is a mechanical process of moving air into and out of the lungs. It's mechanical. We're going to talk about that. We're going to talk about the neuro response to respiration, how the respiratory center of the brain communicates to take a breath and then to expiration, how that works. Because again, critical decision making when you're in the field and you're trying to come up with what's wrong, you need to understand, am I dealing with a problem here on the respiratory side that's coming from the brain? Stroke patients, brain infections, trauma can cause problems in the respiratory center of the brain, and that's going to cause your patient not to be able to breathe. It's important to understand that. It's important to understand the mechanical process of breathing. When I mention mechanical, I'm not talking about gas exchange. I'm talking about the diaphragm. I'm talking about the intercostal muscles. I'm talking about the rib cage. All of that is mechanical, and you have to understand what their role in the respiratory process. That's extremely important. So we're going to talk about that real quick. All right, so bear with me here just for a second while I try to make my attempt to use my pen here. Let's see here. Put this on the other side. All right, so here's our brain. Maybe it's happy today, I hope. Let's draw our trachea real quick. Let's draw a quick bronchial. Here's a lung. Maybe it's a lung. Best I can do, guys, gals. All right, let me put in some ribs here real quick. All right, so let's talk about the neuro side first and what is going on. So the brain provides a stimulus to breathe. Okay. Sorry. All right, that's stimulus to breathe, and most specifically, it's going to be in the medulla. Okay, and then we're going to get even more specific and call it the pons. All right, so we have the stimulus to breathe coming from the brain, but it's got, what is the CNS? Well, the CNS is a bunch of signals, right? It's either sending a signal or it's receiving a signal. That's when we talk about it. So that's what we're talking about. And so let's see here. And so in order to send a signal, you have to have a receiver. So let's draw let's draw some muscle here. Okay, there's some muscle. Now let's put a receiver on it. All right, so there's a receiver. All right, so we've got a receiver. All right, so we're going to send a signal out, and it's going to go down to the pharonic nerve. I'm sorry, it says the pharonic nerve. So let's label that, or phrenic, however you want to say it. All right, and the muscle has a name too, right? All right, and so that's going to be your intercostal nerves. Oh, I'm sorry, we're talking about the muscle. So that's going to be your external intercostals. All right, external. These are the ones between your rib cage. All right, and so they're gonna get innervated. They're gonna get this receiver is gonna receive a stimulus that's gonna tell this muscle to contract outward. Okay, it's gonna contract outward. Why? Because we need to expand the chest cavity. Okay, so that's happening. That's happening. Let's draw a diaphragm. Okay. So our diaphragm is going to receive a message too, but we got to have a way to receive it. So here's a receiver. All right. All right, so via the pharonic nerve again. Via the pharonic nerve, it's going to receive a stimulus, and it's going to tell the diaphragm to contract downward. Okay, so it's going to contract down. And so what you're doing here in this process is you're allowing the lungs to stretch out and expand. That's what you're allowing for. And when that happens, it's going to create a pressure gradient. Okay? And it's going to allow air to be pulled in from the outside, down the trachea, and into the bronchioles, eventually reaching the alveoli. We'll call that an alveoli. All right, and so, like I said, it's going to create that pressure gradient. And so since I mentioned pressure, let's talk about atmospheric pressure outside the body. Atmospheric pressure is around 760 millimeters of mercury. What do you think is going to happen here to the pressure? Okay, so the pressure here in this case is going to go down. Okay, and so we're going to be around 758. And when I talk about a pressure gradient, what I really mean is that we're going to get a vacuum. Okay, so what does a vacuum do? It sucks air in. Okay, so it sucks air in to allow us to breathe air in and go down the trachea. But I want you to think about it for a second, because this has another meaning to it. What if some type of accident happens and the chest wall is penetrated? Notice I didn't penetrate the lung. I just penetrated the chest wall. Okay, well, that's going to allow air from the outside to rush in. Okay, so you're going to have air from the outside rushing in inside the chest cavity. And what that's going to do is going to put pressure on this lung. And this lung is going to then be forced inward. And it's going to collapse. And what about the trachea? Well, it's going to push the trachea in that direction too. We call it the unaffected side. So when you're looking at the trachea, it will be pushed to the uninjured side. And all of this is defined as a pneumothorax. All right, so this is inspiration. All right, and this is a pneumothorax. All right, that's inspiration, but we need to talk about expiration now. So that's what happens in inspiration. What about expiration? Okay, let's draw a trachea. Draw a quick set of lungs. Maybe we'll call that an alveoli. We'll throw another one in here. All right. Again, so the brain's going to play a role in this too, okay? The brain is going to play a role in this. And so let me hang on 1 second. Let me draw a quick diaphragm. Okay, we're doing good. We're doing good. Let's draw a little receptor on here. All right. This is the vagus nerve. Vagus. Okay. All right, so this is the vagus nerve. And it's going to send a message to the diaphragm. Instead of contracting, it's going to ask it to relax. Let's talk about this part of the brain, though, that this is happening at. It's called the Apnewstick Center. Apnewstick Center of the brain. And not only is it going to ask that to relax and move up, but it's going to ask it to inhibit respiration. So the signals for respiration are going to be paused. Okay, we need to pause them so that we're not breathing in. And in order to not blow a lung, we have some different receptors, if my pen will work. And these receptors can be found in the bronchioles, in the chest wall. Okay, and these guys are called stretch receptors. Okay, and these stretch receptors also receive information from the vagus nerve. And they relay information to the vagus nerve. And they say, hey, we're too full, so we don't need to keep breathing in. And that way you don't get too much air in your lungs in order to, end up with a pneumothorax. Okay. All right, and so what about pressure? We're going to, I forgot to, hang on 1 second, draw some ribs. There we go. So here's our ribs, and we know what's in the middle, so it's the intercostal muscles. And so we know that they have receptors, right? All right, we have those intercostal muscles that are attached to the ribs. They have the receptors there. Okay, and so they're going to receive a message. To relax. We need these guys to relax. So that the lungs can recoil. Okay? So when the lungs recoil, they're going to go back in. All right, and this is a natural response. They like to recoil, and it's a no energy cost. It requires no energy. The only time we get involved in energy is if we're having to force air out. So what about our pressure here? Well, our pressure gradient, with all of this going on, it's going to cause a pressure gradient. It's going to force air out of the lungs, okay, which is a good thing because we've got to get rid of CO2. All right, so we're going to have air going back out at this time, and our pressure here is going to be 762. Remember, atmospheric is 760. When we did inspiration, we were at what, 757? All right, so you can see the pressure gradients, and this, that's how we breathe. That's the neuro response and how we breathe. And the reason why it's important is, what if you have an injury to your spine that blocks the vagus nerve? Or what if you have an injury to your spine that blocks the Pharonic Nerve? Well, then we have problems, right? And so we're going to have problems either with inspiration or expiration. So this is how you figure it out. Okay, so I just mentioned ventilation being the process of moving air in and out of the lungs. I'm just catching up on some notes real quick. Yep, talked about all that. All right, and so again, respiration. Here we have, let's see here. We're talking about the capillaries right here. We have a capillary. We have blood cells here, red blood cells, that's carrying hemoglobin, carrying oxygen, and we see how this works. We see how the oxygen here is moving into the cell and how the carbon dioxide is moving out. We know this. If you don't know this and you're struggling with it, come see me so we can get it fixed. We talked about the stimulus to breathe coming from the respiratory center of the brain, specifically the medulla. We talked about how important the diaphragm is and how important the intercostal muscles are. The normal inspiratory reserve volume is about 3,000, something like that. Then we have expiration. We talked about mechanical receptors that send the signal to that Apnewstick Center to inhibit that inspiratory center, and it allows expiration to occur. We talked about these being found on the chest wall and in the bronchioles. It's called a feedback loop, and all that is just if you just think about a loop, excuse me, signals being received, and then new signals being sent. You should know about the Herring-Brewitt reflex, and that's basically what I just described about the lungs not being able to overinflate. We do need to talk about your relationship between the inspiratory and the expiratory. It's called IE. So it usually shows inspiration being 1 and expiration being 2, because it takes twice as long to get air out than it does getting air in. And why that's important is when we compare it to disease processes. If you have an asthma patient, you're probably if they're serious, you could be looking at a 1-to-3, 1-to-4 ratio, where 1 inspiration, and it takes me 4. If it takes me a second to breathe in, it's going to take me 4 seconds to breathe out. Okay, guys, we've been going now for about 30 minutes. I think I'm going to take a break here. And I'm going to try to limit the videos to 30 or 45 minutes and where to get a good break point. So I'll see you on the next video.